All right, everyone. It is 12:01, so I think we should go ahead and get started so we have enough time for a good conversation at the end. My part here today is short. I'm going to just briefly introduce Dr. Glennie. Today is one of our endowed lectures, and so I'm excited to introduce Dr. Rob Glennie, who is the head of the Division of Pulmonary Critical Care and Sleep Medicine, who will tell us more about our speaker today for Grand Rounds. Thanks, everyone.
Thanks so much, James, and good afternoon. Welcome to Medical Grand Rounds. And as James said, the John Butler Endowed Lecture. Before introducing this year's lecture, I want to provide a little background on who John Butler was and why we have a Grand Rounds named after him. So John Butler, or JB as everyone knew him, began his medical education at the University of Birmingham in England, where he focused on lung mechanics. He spent 1 year in Arthur Dubois' laboratory in Philadelphia, and later was invited to the Cardiovascular Research Institute in San Francisco, where he worked with Julius Comro. JB was recruited to build the Division of Respiratory Diseases at the University of Washington in 1965. He had a vision for a new subspecialty that included scientific research and clinical excellence, and he deserves a great deal of credit for the success of our current division. I had the great fortune to have known JB. He was a true English gentleman, very kind, thoughtful, and a very creative scientist. You can read more about him in the brochure. You can also see in the brochure that we have a long list of prior lecturers. Each year, a committee identifies an individual who is an international leader, has a broad interest in pulmonary and critical care medicine, and a deep commitment to working with young investigators. We are fortunate this year to have Marc Moss as our JB lecturer, who embodies many of JB's leadership qualities and commitment to mentoring scientists. You can also read about Marc in the brochure, but as a way of a brief introduction, Marc began his medical education at the University of Pennsylvania, and where he did his residency in internal medicine. He then moved to the University of Colorado for his pulmonary and critical care fellowship, and then Southeast for a faculty position at Emory. Colorado eventually figured out what they had lost and recruited Marc back to Denver to be the head of critical care, and now the head for the Division of Pulmonary Sciences and Critical Care Medicine. He has garnered numerous teaching awards and presidential commendations from the American Thoracic Society. His research is well funded through multiple grants, including 2 R01s and 2 U01s that focus broadly on outcomes for patients who survive critical illness and the consent process for patient-oriented critical care research. He is very active in our premier clinical and research society, being a past president of the American Thoracic Society. He has over 150 publications and even more national and international invited lecturers. I think Dr. Marc Moss is the ideal speaker to represent the John Butler Lecturer. Please join me in welcoming him to Grand Rounds today.
Thank you so much for the kind invitation. It's a real honor to be part of this lecture series, seeing what great visionaries have spoken before me. It was nice to hear a bit about JB and be honored to participate in his lectureship. This is my disclosure slide. I don't have any disclosures for this presentation, or to be honest, any disclosures in general. And I just also want to bring up that, boy, Seattle has such a premier pulmonary critical care division. This is just pictures of people that I really consider colleagues and friends that I've met through different societies, being on study sections, etc. So it's kind of feels like there's a symbiotic relationship between the pulmonary division at Denver and in Seattle. And I just, it's an honor to be asked to speak on behalf of the pulmonary division. Also, in terms of friends, I just want to give a shout out to Randy Curtis, who pseudo adopted my son. And this is them skiing prior to the pandemic together. And it just shows, again, the camaraderie between the two divisions and the pulmonary critical care divisions around the country in general. And I want to start off with the acknowledgements. We always put them at the end, but this work, which started off as a side project, that Meredith Mueller started to work on close to 20 years ago, and has really grown to be, as Rob talked about, funded research from both the NIH and the National Endowment of the Arts, where 20 years ago, if you told me the NIH was going to fund this research, I would have said, I think that's highly unlikely. But this is really a team effort of people from multiple universities around the country. So I also want to start off with some take-home themes and messages so people kind of understand what we're going to talk about. In terms of wellness or burnout in healthcare professionals, it's really an occupational health crisis. I don't really view it as a mental health issue. And we'll talk a little bit more about that. And as you'll see on a slide, this is much deeper than just burnout. There are some more significant psychological distress. And because there's this more deep psychological distress, we have to figure out how to reduce the mental health stigma if we're going to make headway on this for healthcare professionals. Effective strategies will need support from all components of healthcare. Sometimes people talk about individual versus organizational interventions, and I really think they're very similar, and any interventions that we'll talk about will need input and support from organizations. We need to promote effective leadership. And as Rob talked about, and I talked about a little bit, it's really an essence of this is maintaining a strong sense of community, which was difficult to do during the pandemic and beyond. So this is not a new problem. A few years ago, I read this book called Team of Rivals. I don't know if you've read it. It's about how Abraham Lincoln put together his cabinet. It was written by Doris Kearns Goodwin. And what Lincoln did is he put together people with very different skill sets to make a more effective team. And as I was reading through the book, they talked about the Civil War was going on, and Walt Whitman, a famous poet, and Louisa May Alcott, who wrote Little Women, were both volunteering as nurses at Army hospitals during the Civil War. And Whitman said that he felt sick and actually trembled at night, recalling in death, operations, and sickening wounds, perhaps full of maggots. And Louisa May Alcott said she found it difficult not to weep at the sight of several stretchers, each with legless, armless, and desperately wounded occupants. So again, the tragedy and the difficulty we see in medicine has always been there. There are things that have clearly changed since the Civil War. The second thing I want to do is show a short video from the TV show MASH. So this was a very popular show, and it's important that this came out in 1980, so over 40 years ago. And at the time, one of the surgeons in the show that dealt with a mobile surgical hospital during the Korean War got the mumps and had to be quarantined. So they had another doctor who was extremely well trained, a surgeon from, I think it was Mass General, and trained at Hopkins, and he was considered the best surgeon in Japan, in Tokyo, came up to the MASH unit. And he started to become a little unraveled working in a medical environment with decreased resources, where he had to make ethical decisions that if he saved this person's leg, he might lose someone else's life due to the shortage of time and resources. He became a little unraveled, lost his temper a little bit in the operating room, threw a few surgical instruments, and then at one point at the end of the show, he ran out of the operating room. No one could find him until he was found sitting on the floor of one of the tents. So Rob, I'm going to play this, and if you can just make sure we can hear the sound.
The blood won't come off.
Sounds perfect, Mark.
Great,
I
thank
do,
you.
it just stays there. Just take it easy. See what I mean? Look at that. It's never gonna go away. No matter how hard I scrub or How much I wash? It's gonna stay there. Where did they come from? What do they expect me to do? I can't. I can't.
Now, for those of us who watched MASH, when I asked the question in a live audience, many people remember that episode because it was a very moving episode. And I think it shows, again, that over 40 years ago, we had difficult jobs and had to deal with a lot of stress and trauma. And sometimes it was hard to deal with. So these are two quotes that talk about, is our profession out of balance? And one is, with altruistic intent, healthcare professionals may place professional responsibilities above personal responsibilities. And though admired, this may be self-defeating in the long run. And the second is, role models range from academic superstars with impressive research credentials and international acclaim to committed clinician teachers who are at the hospital 7 days a week. Their heroes live lives that are desperately out of balance. So what is burnout? And I think the importance is it's the discrepancy between what you thought the job was and what you're actually doing. So none of us went to medical school or took a job in healthcare, the profession, to sit in front of a computer and write notes. So there's a very good example of, that's not why we studied in medical school. We thought the job was going to be different. The other thing is that it's clearly a work-related problem. People don't start a job with symptoms of burnout, but they occur gradually over time. And often people don't even notice the change in themselves, but maybe their families or the people they work with do notice those changes. And it also happens in the best and most idealistic employees. These are not people that have prior psychiatric history. They're the ones, and we've studied this, that went into healthcare to help people. And they're the ones that you would want to be your healthcare professionals, because they really care about their patients. The most idealistic healthcare professionals are the ones that are the greatest risk. Now, this is a very important slide, and I alluded to it. We talk about burnout, and I think people go, well, it's a problem, but it's not a really big deal. But what I think is important is, first of all, it is a big deal. And embedded in burnout are deeper mental health and psychological problems that stem from an occupational health issue. People have higher rates of substance abuse, depression, anxiety, PTSD, suicidal thoughts. And each year, 400 doctors commit suicide in the United States. And if you think about that, that's about 2.5 med school classes. That's not okay that is occurring. And then COVID hit, and it made this even stressed environment even worse. So let's talk a little bit about what COVID did to the epidemic of burnout in healthcare professionals. The first thing it did is it raised awareness to it, that people were more comfortable talking about it. And I think the important thing is it follows this kind of natural sequence of what we've seen in the past during natural disasters like tsunamis or earthquakes, where, and this is a normal response, initially there's this sense of heroism. And I think many of us found ourselves saying, this is why we went to medical school. This is why we did a pulmonary critical care fellowship. These patients need our help. This is exactly what we were trained to do. And a lot of the difficulties building community broke down. Surgeons were talking to anesthesiologists, getting along with medical doctors, because there was a common vision and there was a common mission. The patients needed our help, and a lot of the barriers broke down, and people worked together in this community cohesion in sort of this honeymoon period. But then after a while, that sense of heroism and the honeymoon period went away. And there's this long stage of disillusionment. And I kind of feel we're still in this, even though a lot of the rest of the world wants to and has felt like they can go back to normal. So let's talk about this disillusionment. So the first thing that happens is it really sinks in that we're going to be doing this for a while. People get exhausted, they get fatigued, and then a lot of the support systems and the volunteers pull out. The Denver Broncos were sending us meals for the first few months, and then they kind of stopped sending meals to the hospital. And people wanted to get back to a normal lifestyle. And the people that were still working in the hospitals felt abandoned or maybe resentful, where people are like, pandemic's over. And you're raising your hand going, we still have 40 COVID patients in the ICU. And I'm still sleeping in the basement of the house because there aren't any vaccines at the time. And so people want to go back to normal. People start arguing a little bit about, well, I didn't realize the anesthesiologists didn't get paid for the extra shifts, but the medical people did. Is that fair? Is that not fair? So this honeymoon period where people were working together starts to break apart as people get disillusioned. And then there's inadequate disaster response where, like people aren't taking care of us anymore. People expect us to do things that we can't do. And it's a natural response, and it leads to longer term effects of burnout and other types of psychological distress as we're recovering from the pandemic. So we studied this. This was a study we did with Karen Burns from the University of Toronto, where we sent surveys to 62 sites in Canada and the United States. And this was conducted in the spring of 2021, so about a year into the pandemic. There were site leads that distributed questionnaires to at least a third of their attendings, or 10 potential recipients, whichever were more. And overall, we got 431 responses from, and again, these were physicians, not trainees. Just keep that in mind. And what the survey showed is a few things. Number one, there was this dichotomy between balance and the satisfying parts of caring for patients that needed our help, but it was physically and emotionally exhaustive. The people who were non-intensivists who got pulled into working into the ICU felt more moral distress because they thought they were caring for patients that they maybe weren't qualified to care for. And that most of the items that incited the moral distress in general were due to organizational or institutional issues that compromised care due to the lack of resources, the excessive documentation that we didn't feel that was very necessary for patient care. So things that could in the future be fixed to decrease the moral distress that was occurring during the pandemic. The other thing that was concerning is we asked people what coping mechanisms they used. And a lot of people used healthy coping mechanisms like acceptance, talking to other people, positive reframing. But what was concerning here is over 30% of the respondents said that they've been using alcohol or drugs to make themselves feel better, or using alcohol or drugs to help me get through it. So substance use, I can't say abuse, in over 30% of the people that responded to the survey. And when we looked at it a little bit deeper, there were sort of 4 different groups of how people were coping with the stress from the pandemic. There were people that were sort of active and social that were using positive reframing. About 46% were just in denial, self-blame, using substances, trying to distract themselves and pretend that, the stress wasn't really there. There were some that kind of flipped back and forth. And then about a 30% we would say were infrequent copers. They were people that in general felt they were very well balanced at a baseline and didn't need to do anything above and beyond what they were normally doing. And not too surprising when you looked at the association between these 4 styles of coping, the ones who were avoidant and ambivalent had the highest rates of moral distress, burnout, and the lowest rates of professional fulfillment. I do want to point out that this study was, as I said, conducted in North America. And one thing that's interesting, if you look at other studies from around the world about how people dealt with the stress and what coping mechanisms they used, a study out of Pakistan, religion was the most common coping mechanism that people turn to in times of stress. So there are different ways to do this in a healthy way, and there are unfortunately ways that people turn to in an unhealthy way. So what's interesting is when I used to give these talks 10 to 15 years ago, the entire talk was about this is a problem, see how many people have symptoms of burnout and PTSD. But what's nice is now, 15 minutes into the talk, we can start to turn to some potential solutions about what we can do about this epidemic of burnout and other forms of psychological stress. We're going to talk a little bit about how to reduce stigma, organizational solutions, individually focused interventions, proper leadership styles, and then a little bit about roles of societies or organizations. So in terms of stigma, this is a big problem. There's a mental health stigma in the United States where people feel comfortable saying they have cancer, but they don't feel comfortable saying that they have depression or anxiety. So this is a survey that was done by Tate Shanafeld when he was at the Mayo Clinic, and Tate was a resident at the University of Washington and did some of his preliminary work in Seattle. But in this survey of 6 medical school students, about 800 people or students, 52% had symptoms of burnout, and 33% of the ones who had symptoms had sought some type of help, whether it was talking to friends or professional counseling. But what's interesting, when they answered the questions like my supervisors, faculty, residents, or deans would see me in a less favorable way if they believed I had an emotional mental health problem, over 50% of them said that they agreed or strongly agreed. And if they said if I'd received treatment for an emotional mental health problem, I would hide it from other people, close to 60%. And when they said residence directors would pass over an application if they were aware I had a mental health problem, that was close to 50%. That's a problem. People are not comfortable sharing that we deal with tragedy on a daily basis in medicine, and we're supposed to just deal with it. So how do we reduce stigma? The first thing, as I've said several times, it's an occupational health problem. It's not a mental health issue. It's part of what we do. It's no different than this coal miner. No one ever blamed the coal miner if he came in with a coal miner's pneumoconiosis. We can protect them, but it's not his fault that he got lung disease. It's part of his job. And I think this burnout and psychological stress is part of what we do, and we have to accept that. Now, other groups have accepted that. Social workers figured this out a long time ago, and they have incorporated wellness and wellness training into their educational curriculum and into their workflow. And one way to do this is to have leaders tell personal stories to destigmatize this. And we're starting to see this around the world. There are famous writers, actors, actresses, J.K. Rowling, Lady Gaga, Selena Gomez, Emma Stone, Dwayne "The Rock" Johnson, have all said, we have mental health issues, we have depression, we have anxiety. Athletes, it became an issue at the Olympics when Simone Biles talked about how she was done. She was too stressed out to perform at the Olympics. Naomi Osaka dropped out of, I think, the French Open. I can't remember which tournament, just too much stress in her life, not worth it. Michael Phelps, Terry Bradshaw, Lindsey Vonn, Serena Williams have all started to talk about their mental health issues in a very constructive way. And we need to continue to destigmatize, because otherwise people are not going to feel comfortable talking about these issues, which, as I said, is an occupational health problem. The other thing from organizational issues, and I've said this way too many times at meetings, medicine's run too much as a business. I understand it's a business, but if it was just a business, I would have gone to business school like some of my friends from college. And unlike some of my friends that did go to business school, I am not retired with a home on Nantucket Island. Many of us went into medicine due to the altruistic nature that we want to help people. And it's that feeling of being altruistic has been taken away from us. We also shouldn't be asked to perform repetitive, meaningless, low-value work. And I think, as I said, organizations sometimes will take advantage of our altruism. If you ask somebody like, hey, can you see another patient in clinic? They really need to see you. Most of us are going to say yes, because we want to help people. But after a while, you kind of feel like maybe you're getting a little taken advantage of by the system. The other thing is administrators need to understand what our concerns are, and vice versa. There's this dichotomy, this schism between hospital administration and healthcare providers. We need to understand their stresses also and what they're looking at, and there needs to be better communication. And as I talked about, even individual interventions, people talk about yoga, whatever, not to downplay the importance of that, they need approval from organizations, because the last thing anybody wants is, after working a very long day, 14 hours or whatever in the ICU or in the clinic, the last thing you want to do is say, okay, now you get to go to your yoga class, or you get to go talk to a therapist. That should be incorporated into our workday as part of our job, like social workers have done. So in terms of individual interventions, there are a few caveats. The first is, if they're not implemented properly, it puts the blame on the staff. Nobody should blame Sonny Liston here for being knocked out by Muhammad Ali. It's not his fault. He's a boxer. It's part of what he does. And now maybe he could be a better boxer in this thing, but we need to give him the skills to become a better boxer. It's not fair to blame him that he got knocked out. It's part of his job description. Interventional and interventions, as I talked about, need to be integrated with the organization. I was taught this, that you don't survey people unless you have solutions. So what happened at one program is they started to survey all the residents and found out that a lot of them had symptoms of burnout. And then what happened is they started to tell the residents that they had to do stuff after hours to help with their burnout. When they resurveyed the residents, surprisingly, no one had symptoms of burnout anymore, because nobody was willing to answer the questions accurately, because you were adding work onto their day. And that's just going to stress people out. And again, the other thing is, don't minimize the amount of time this takes. I remember when I started doing this work, I went to talk to one hospital administrator at another hospital in Denver about seeing if some of their healthcare professionals would want to participate in some of our studies. They're like, oh, we're taking care of all this. It's like, well, I'd love to learn what you do. And they said, well, once a year, we give a 40-minute lecture on burnout and wellness. And that's not enough. This is really a lifestyle change that has to occur as part of an organizational culture. It takes more than a 40-minute lecture once a year. So here's some of the things we've done, not evidence-based, in our division at the University of Colorado. Number one, we monitor and encourage people to take their vacation time. It was very common. People don't do that. And when people are on service in the ICU, we again encourage people to take the next day off, and just, you've worked 7-10 days in a row, take a day off and just don't worry about your work. I was talking this earlier with some of the faculty at in the pulmonary division. We have a policy, I wouldn't say it's a rule, where we encourage people not to send emails after hours. After 6 p.m., before 7 a.m. or on weekends, we do not encourage people to send emails. If you want to write emails, you can send a delayed delivery, and they'll be delivered the next morning. And if it's something that important that you need to talk to someone, pick up the phone and call them, or send them a text message, especially if it involves patient care. The other thing we did during the pandemic was we financially incentivized members of our division to go see a mental health professional, whether it was as an individual appointment or in a support group. And we had close to 50 faculty members take advantage of this. And many of them have continued on with their mental health care professional or their support groups over time, because once they got their foot in the door, they saw the value of it. The other thing is, I read this book called Together. It was written by Vivek Murtry, who's the current Surgeon General of the United States, and he studies the health effects of isolation. And in this book, they talk about blue zones around the world. And what blue zones are there areas in the world where people have a very long lifespan. There's something in the chat. Okay, I'll get to the question later. Where people live a long time. And when these blue zones have been studied, many of them are in Greece or in Japan, and they look for common interests or common reasons for longevity. Part of it's genetics, part of it's diet, But one of the stronger factors was a sense of a commonality of a community where people looked out for each other and had common interests. So it's not just putting together in a group. So if I told somebody who's not interested in music to go to the orchestra, they might, with other people, they might not get that sense of community. But if I asked them what they like to do and then put them together with people that had a common interest, that builds that sense of community. And we did that during the pandemic and created multiple Blue Zone groups, where they were book clubs, Peloton groups, groups for people that had young children, dog daycare groups, etc., to put people together in a common interest. And many of these groups have, again, continued after the pandemic. The other thing we did, and this is work funded by the National Endowment of the Arts, is we got interested in creative arts therapy. It was a RFA that came out from the NEA, and we applied for it. And really what creative arts therapy is sometimes the traumas that we deal with at work, they're hard to talk about. And sometimes if you give people another medium and give them music, art, movement, writing, it allows them to express the emotional distress they're having. And then once it's out on paper, they can, with a group and with a creative arts therapist who's a trained therapist, really delve into those emotional impacts of what's going on and come up with skills to fix it. So it's really group therapy, but under the auspices of creative arts. If you're interested more in this, we have a very prolific website with videos, etc. And this is a paper we wrote outlining the impact of creative arts therapy. To give you a little bit more insight, I'm going to show you one about 2.5-minute video that explains one form of therapy, art therapy, and gives you a little insight about what the sessions are about.
Hi, I'm Stephanie, and I am a certified child life specialist. The thing I love most about my job is the fact that this is really the perfect blend of what I wanted. I wanted to be in healthcare, but I didn't have to do those invasive procedures, and I could help children understand their experience and really master it. But my job is really hard. I have had to explain to kids when they're gonna die, and that's not easy.
I'm Catherine, and I am an art therapist. It's taxing emotionally on our healthcare professionals to be there every day for these kids when your heart is breaking. And what do we do with the pain, with the trauma, with the sadness? And what we've found is that bringing creative arts therapy into the room, there is a natural healing element that is almost magical in a sense.
As a child life specialist, I use play as a way to educate children, to help them feel that this environment that they're in, the hospital, the clinical setting, is normal. And I think art really translates that for healthcare professionals, because sometimes it can be really hard to verbalize the frustration or the sadness or the grief that you're feeling. Having that task that everyone is doing puts us all in this normal, calm space, and then we can reflect on what we've done and go even deeper. And I think that's where that therapeutic level comes in, is the combination of that facilitator and the group discussion.
What is happening across the country is that healthcare professionals are getting exhausted. We are often asked to do more than what is emotionally healthy for us. We don't really expect our nurses and our doctors to admit that they are sad or to admit that they are tired even. Choral is a potential answer to that problem. To have a place where those truths can come out and can be explored and processed and then shared with other people, I think is an incredible way to build community.
This program has helped me understand that I am a strong person and I do have skills and I am capable of being a really great child life specialist, but sometimes the scenarios that I go through are just really hard. Having that resource available to team members, to staff, to employees is just invaluable.
So what we did is we conducted a pilot randomized trial where people were randomized to 4 different types of creative arts therapy: art, dance, movement, music, writing, or a common control group. And what the intervention was is people attended a 90-minute session once a week for 12 consecutive weeks. Initially, the sessions were focused on creating safety. The second part, coping, expressing. And at the end, they participated in a group project, whether it was creating an anthology of writing, creating a song, etc. And working together, they learned how to rebuild this sense of community. The control group and the participants filled out questionnaires before and after the intervention, and then we have new data at 4, 8, and 12 months after the intervention time period. Here you can see who participated. In general, the majority of participants, 50%, were nurses. About 20% or so were behavioral health specialists. About 10% were doctors. And this study was conducted during the pandemic. In the first group, it was prior to vaccination, and we had to make sure we did it all safely. But what was interesting is that this is one of the first studies I've ever conducted where we had a wait list of people that wanted to get into the study if possible. In general, these people had worked in healthcare for approximately 9 years. And again, these weren't novices to mental health issues. About 30% were taking medications for anxiety, about 25% for depression, and again, about 35% or so had already participated in other forms of therapy or counseling. And when we look at this, these are the different symptoms of anxiety, depression, post-traumatic stress disorder. And these are the 3 domains of burnout: emotional exhaustion, depersonalization, or decreased personal accomplishment. The intervention group shown here, change in baseline, is in black. And for all the ones except decreased personal accomplishment, a diminishing of the score is an improvement in their symptoms. For decreased personal accomplishment, an increase in their score shows that they have less decreased personal accomplishment. And you can see that there are significant changes in the intervention compared to the control group in symptoms of anxiety, depression, symptoms of PTSD, and all 3 forms of burnout. If you look at the data in a slightly different way, and some of these you can stratify as either having positive or negative symptoms. If you look at those that were in the control group, about 60% of them had symptoms of anxiety pre and post. Again, they just filled out the surveys before and after the 12 weeks. There was no attention control group. But in the intervention group, the symptoms of anxiety, or people that would be test positive for anxiety, dropped from 72 to about 39%. For emotional exhaustion, it got worse in the control group and improved by about 10% in the intervention group. And for depersonalization, about the same, and dropped by about 16 points in the intervention group. So really dramatic improvements in symptoms. This is brand new data that we got maybe about last week. And it's a complex slide, but the solid lines are the intervention groups. The dotted lines are the control groups. And yellow is depression, red is anxiety symptoms, and purple symptoms of PTSD. And what you can see here is even after the intervention ended up to a year, the effect of the intervention appears to remain in those people that participated in the intervention with significant persistent improvements in symptoms of anxiety, depression, not quite PTSD, between the control group and the intervention group. What's interesting is the symptoms of PTSD in the control group decreased dramatically over time. This might be that, the pandemic was over and maybe some of those symptoms, as the pandemic got better, went away. So what are the limitations? As I alluded to, we didn't have an intention control group. It's an unblinded study, and it was conducted during the pandemic, which was an extremely stressful time, and maybe doesn't transmit to non-pandemic things. So I'm not sure that's true. We had regularly developed protocols, variety of healthcare professionals, showing that this sense of community is important, extensive outcomes, and we only lost 2 people to follow up after they were randomized. We then did qualitative interviews with the participants, and the thing that came across the strongest was what this program did is build a sense of community. It built a sense of community with participants that had different disciplines, roles, and geographic diversity. It also was important that the intervention was held off campus to create some separation between the primary place of employment and where the program was occurring, partially due to creating a safe space. The facilitators people loved and were very good at their jobs. We want to make sure we figure out how to reproduce that. The group project was also very important, again, to build this sense of community. People felt it was important to be pushed out of their comfort zone through the creative activity. And when we specifically asked, would you maybe just want to do the art or just do the group therapy, everyone thought it was very important that it was this commingling of the arts with the group therapy together. The other thing we've studied a little bit is the sense of leadership, and there are a lot of different leadership styles that work in different environments. The leadership style for a college football coach in the South probably is not going to work in a division of endocrinology or any form of an academic medical center. In general, improvements in leadership styles are associated with improvements in burnout. But the question is, what's the right leadership style for an academic medical center? So prior to the pandemic, we conducted focus groups of 3 different sites in the Department of Medicine across 4 different what we called affinity groups. We didn't just study faculty, we studied clinical faculty, research faculty, trainees, and staff. And then we conducted 12 focus groups with these different individuals in groups, led by a trained facilitator, to try to get some idea about what type of leadership styles people wanted. And what came out was very clear that people want what's called an authentic leadership style. People want individuals as leaders that have balanced processing, that come to the table without their mind made up, that they're good listeners, that they try to incorporate what the group wants into their decision-making, that they're very transparent and honest, that they have moral perspectives and they have a lot of trust, and that they show and model the right behavior in terms of work-life balance. So they're not working 7 days a week doing those quotes that we talked about, but telling people to take time off. They're modeling the right behavior. And then we talked a little bit about how can we enhance leadership styles. Number one is to encourage shared decision-making on units and divisional levels so that people have a voice. Develop formal communication training so people understand that are leaders, how to enhance openness and transparency. Develop formal, authentic leadership training programs for leaders. Embed this training into medical nursing and graduate school. And maybe like when we're recruiting future leaders, that this is something we look for and during the interview process and say, wow, this person really inherently has an authentic leadership style. Maybe that's more important than how many R01 grants they have to determine if they can lead a division or a department or not. And then the last thing I'll talk about is the role of professional societies. So we convened a task force in the Critical Care Societies Collaborative to try to figure out what is the role of professional societies. We conducted focus groups with 17 major US professional societies who primarily work in critical care. But I think what came out of this is not only relevant to professional societies, and it's the reason I incorporated in this talk, but also important to organizations like academic medical centers. And the thing that came across is, I can't see the top, but I'm pretty sure it's like to acknowledge that this problem occurs, to be committed to supporting members with well-being, create collaborations. We shouldn't be reinventing the wheel for each division, department, school. We can all learn from each other, educate and advocate for change. And I think that comes up in one of the questions that was put. We have to foster innovation through research, and this is starting to happen at the NIH and National Endowment of the Arts and other sites where they're actually now funding research on wellness, and then support both individual and organizational solutions. So in summary, before COVID, psychological distress in healthcare professionals was, according to the National Academy of Medicine, the most important issue in healthcare. And I think after the pandemic, it's even more important. And I think this is the proverbial opportunity. The world's now or was looking at healthcare as how are we going to deal with this issue? And I think COVID created an opportunity to finally really realize that we need to help our colleagues and help ourselves. And if we do it properly, then we can utilize the pandemic to raise awareness of the mental health stigma for society and maybe break down some of the mental health stigma issues for healthcare in general. So again, Rob and the entire division, thank you so much for the talk. I really appreciate being asked to talk, and it's really an incredible honor. And I'll stop now and be happy, James, to answer any questions.
Great. Thank you so much, Dr. Moss. We have a couple questions already in the chat, and then I'll invite folks too if they have other thoughts, so please share them. I think up front, one question was raised about sort of your practice of encouraging days off and how that relates to clinical productivity and whether like the days off that people take are accounted for in that.
Yeah, I think we're really, when people, I have a slide sometimes I didn't show it in this one where, like, again, medicine's being run as a business and it's way too much that way. And we're kind of missing the forest through the trees. Everyone's like, how many RVUs did you have and whatever? But if everyone's going to quit their job and we have this turnover, we have to factor that into it also. So, I mean, what I did, it worked out okay. During the pandemic, I said, we're not going to talk about finances. I'm happy to show people the finances, but we got enough stress as it is. If you're concerned we're not doing stuff the right way, I'll share it all with you. But we're not talking about productivity. We're not cutting people's salaries. We're not furloughing people. We're going to take care of patients, and we'll figure out on the back end. Now, I could get away with that during the pandemic. Now people are like, we got to get back to productivity. But I think it's an opportunity to say, these are important metrics, but we can give people a day off and they're still going to be productive. So I haven't quite figured that out. I wish I had the answer, but I think people are starting to see that if everyone leaves their job, turnover is expensive. I can tell you, I know the numbers for nurses in an ICU, it costs over $1 million a year in turnover costs. You can fix that with RVUs very, very quickly.
A similar sort of follow-up on the topic of those days off was wondering about that seems to work very well when folks are on an inpatient service and then can kind of take the day off once they're done and don't have responsibilities. But for some of the outpatient providers who still have sort of an inbox or other things, that really requires them sort of then shifting that work onto their colleagues, which in a different way can feel difficult. And so wondering if there are any solutions you all have thought about for working with some of the outpatient providers.
It's interesting. I get different answers. So I've talked to some of the leaders in the field in this area. They're like, you're not going to convince hospitals to give you time off for this. Okay. I'm not sure I agree with them. I think we need to continue to push for that. So again, there are all these activities we get asked to do that are above and beyond all these HIPAA training things and fire safety trainings. And, sometimes you have to do those things. We're not given time to do those. People are doing that on Saturday morning. The city trainings, they're all important. I'm not downplaying it, but where's the time for that? And there was a proposal that got put through the Children's Hospital that got rejected, but I think it's the right type of thing where we should be given 5% of our time for these activities. And I think if you start to do that, people will then be happy to or 5 to 10% will be happy to see that extra patient in clinic. So it's going to come back that everyone's going to be able to do the work, but it's done in a much more gentle way. Now, I'm not sure how to convince hospital administrators, except there's great data that the turnover is extremely expensive. And I can tell you there have been surveys of ICU nurses during the pandemic. This is really scary. 75% of critical care nurses are seriously considering leaving their job in the next 6 to 12 months. If that happened, we don't have a healthcare system anymore. So, at some point, people are going to have to realize they're going to have to incorporate this, or, part of the system's going to fall apart.
Absolutely. Another question was asking just to expand a little bit more on when you were mentioning within the social work profession that this seems to be a bit more integrated into folks' workflow. What practically does that look like?
It's interesting. I'll tell one story really quickly. So, and I've asked this 1,000 healthcare or doctors, and they all say the same thing. So if you're taking care of a patient and you go home and they're kind of sick and you're worried about them, you might look on the Epic and see that, their pressure requirements have improved a little bit. And you come in the next morning, you print out the list and you see their names on the list. And then you walk over to the nurse that was on at night and you go, "How's Mr. Smith doing?" And the nurse says, "Oh, unfortunately, Mr. Smith passed away." And what people do there is they just cross the name off the list and they move on. And that's not a healthy way of dealing with the stress that someone just passed away. So when you talk about how are we supposed to incorporate these things into our day and how do social workers do it, they acknowledge it. They don't just cross the name off the list. So at the end of the day, and this is, Randy maybe can type in about this or other people in the palliative care, it's very common, they have tough jobs too. They deal with a lot of end of life. People take a little bit of time and say, "James, how are you doing today? That's kind of tough. That family meeting, it's really emotional. Are you doing okay with it?" And they might even say, "You know what? Why don't you come in late tomorrow and we'll cover for you because you took the brunt of all that." They acknowledge it. It's not like on the medical side of things, sometimes we're like, "Oh no, I'm fine. I'm okay. I got this." And we've got to agree that this is an issue, and we need to address it. So that's the way social workers talk about it. They talk about it. How was your day? How are you doing? What do you need? How are you going to take care of yourself tonight, etc. And we suppress it in medicine.
I was wondering, as you were describing the participants in your trial, were they given time to participate as a part of sort of their FTE, or was that extra for them?
Yeah, unfortunately, but interesting. It was extra for them. Trying to get this to be carved out as part of someone's day was almost impossible. And we have a current study going on where we wanted to do it where, those of us that worked in COVID ICUs, you realized it wasn't just the doctors and nurses, it was the custodial people that cleaned the rooms that were also putting their lives on the line for minimum wage jobs. So we tried to put together the same thing in the second round of the NEA grant for the people in the food services and whatever. Trying to get them to get an hour and a half off during the day was impossible. So we did it after work, but it was difficult to do that. And I don't think it's the right model going forward because it adds stuff to an already long day. But it showed how stressed out people were. We, as I said, had waiting lists of people that wanted to sign up even on their own time.
Yeah, I think that's definitely striking because I think that's what comes up a lot, and especially even with our residents who have even limited time after work to try and find space to squeeze this in. But when it's scheduled in for them, it makes it a little bit easier. Another question was just about how you think of burnout as relating to sort of folks' sense of purpose and how whether or not sort of having staff and faculty develop their purpose for their work, if that is in some ways protective or might help decrease burnout.
It's a really interesting question, James, and I think it is important. it gets back to that honeymoon period we talked about. Why did it work at the beginning of the pandemic? It worked at the beginning of the pandemic because it's like, as I said, this is what we're trained to do. We understood the vision and mission of the organization of what the goal was. And I think sometimes it gets back to the business side of things. I think we've lost our sense of purpose a little bit, that medicine, James, you stayed up and studied on a Friday night in medical school, not because you were trying to figure out how many work RVUs you were going to get, because you wanted to take better care of somebody. And that's what drew you and all of us to medicine. So I think you're right. I think making sure that people understand how decisions are being made and why decisions are being made, and it should be. And what I always come down to when I take care of patients is like, let's just do the right thing for the patient, and the rest of it will fall into place. And if someone's trying to dump a patient onto the MIC service, that's somebody's mom. I'm going to just take proper care of them. So I think you're absolutely right. I think the sense of purpose and vision is very important.
Great. And then one last question from Randy that I think gets at a theme from some of the other comments too, is that I think it can often feel challenging, where I think most of us on this call on the clinical side of things feel like we are sort of this injured choir that's being preached to. And in the current moment, both for our own healthcare system, but I don't think UW is unique in this. It feels like the financial reality is always the thing that is brought up as limiting all these things. And so how do you think about, as a leader, sort of creatively addressing this epidemic in the context of ongoing financial difficulties?
Yeah, I mean, I think the issue with that is you've got to speak the language of the people you're talking to so they understand it. So if you walk into a hospital administrator's office and you start talking about nephrotic syndrome, they don't understand what you're talking about, and it's, or whatever the medical issue is. They're business people. They went to business school. So you have to talk their language. And there are a lot of papers out there that show that burnout, psychological stress is expensive to healthcare systems. So a lot of these things we're putting into place in terms of giving people the time to take care of themselves, giving them time to go see a mental health care professional, they'll save money in the long run. The creative arts therapy program probably would cost, I don't know, $20,000 to do that for a unit over the course of a year. As I said, a MICU loses $1 million a year in turnover costs. So if, $20,000 to save $1 million, a business person's going to understand that language. You got to speak their language and hope they understand. And it's like anything. I mean, Randy understands this, we all do. You got to be persistent. I mean, it's very unusual the first time you have a conversation or the first time you submit a grant, they don't always understand it. You have to be persistent with it.
Great. Well, we're just at 1 o'clock. Dr. Moss, I hope you'll take some time to read a lot of really thoughtful and kind comments in the chat. Thanking you for your talk. We really appreciate everyone tuning in for our grand rounds this week, and thank Dr. Moss for speaking with us. And we'll see you all again in 2 weeks.
Thank you so much, Mark. You were the perfect JV speaker.
Rob, thanks again for the invitation.
Okay. Enjoy your Hall of Fame recognition.
Thank you.